share your video with us. It's good to see you all. I see Ben, Rudy, Heather, Danny, Janine. Hey, how are you?
Good.
Let's see. I see Kamika. Hey, Jess. Jeff, good to see you, buddy. Janet. Hey, everyone. Okay. Well, let's see. I'm going to keep pulling people in, and we have a special guest for you tonight. Before we jump into that, I'm going to have Dad do his opening prayer. Dad, do you want to say hi and start with your
Hi, everyone. This is the best looking group we've ever had. Yeah, wow. Well, let's get started with a little bit of a prayer here, okay? Father, we thank you once again for allowing us to come together and share insights on body, mind, and spirit. We ask that you help us keep our egos in check, and we especially ask that you help us to restore our practices to the way that they used to be in as timely a manner as possible so that we can be treating our patients with hands-on, as we know this is something that's desperately needed for them. And we ask this in your name, amen.
Amen.
So
right.
even if that doesn't apply to you, it applies to me, because I still want to get my hands back on people again. So
yeah.
Hopefully you do too. Okay, Eric, you want to?
Yeah. Well, happy Cinco de Mayo, everybody. Thanks for being here. Hopefully you all waited on the margaritas until later. So we have a special guest. Tom Krupar is one of our instructors, and he's joining us tonight. Tom, how are you?
Hey, how's everybody doing? I'm doing great.
Good to see you, Tom. Can you start by giving everybody a little bit of background about yourself, where you are, and your practice experience?
Sure. So I've been a therapist for about a little over 30 years now, and I've been in private practice my entire career, 5 years with a small group nearby, and then started my own practice and worked pretty much by myself, solo practitioner for 13 years. Sold that practice to the group that I'm with now. I'm a part owner in a group of 5 clinics in our county, and just outpatient orthopedics all day, every day. Do a lot of work with, I'd say half my day is spent with pain, neck pain, back pain, chronic pain, fibro, and half my day is spent with athletes.
Awesome. Thanks for being here, Tom. The reason that we took a couple weeks off was that Tom came to us and had an idea for a mini course. We've been working together with him to kind of produce something that we'd be able to share with you. And so we've come up with the name. Tom, do you want to share the name with everyone?
Well, we're calling it the Pelvic Solution. Now, I think the long name is Pelvic Solution for low back pain, but this is a little bit more than just low back pain. We can work on hip pain, groin pain. It's worked pretty well for knees, and in some weird cases, it's been helpful for ankle pain, headaches, and thoracic pain as well.
Awesome. Now, can you share a little bit with everyone about kind of the background on it, how you developed it, how it's different from what other people might be used to seeing as far as the PRRT techniques go?
Yeah, sure. So I don't know. I've always said one of the things I always talk about when I'm telling people about myself is I'm not the smartest guy in the room, but I am one of the more observant people in the room, I think. And so I've always noticed this especially with back pain patients, this counternutation, or at my facility, the folks call it an upslip. I know it's not an appropriate term, but it's easy to recognize. It's easy to visualize. And I didn't know how much it played a role in people with back pain. So about 25 years ago, I started playing with different ways, muscle energy techniques and stretching and mobilization techniques to try to correct it. And I could sometimes correct it, but it would never hold. And so I started playing with this technique more and more. And then long ages ago, met John and learned reflex release technique, and then thought maybe we could incorporate reflexive techniques into what I had already established. And bingo, when I started using reflexes with it, it's a doggone near 100% effective I always tell my patients, it's never not worked. It's always works for me.
Yeah. Awesome. So I'm sure that everybody's excited to see it. How long does it take you to perform the technique, Tom?
The technique itself, probably about 5 seconds.
Pretty quick. Okay.
Very quick. Yeah.
Pretty close to reflex speed.
Very close. Not quite your speed, John, but I mean, it's an Ohio reflex speed.
Things are slower in Ohio.
That's right.
Probably had something to do with the time change. Now, how many patients are you using it on, Tom?
Boy, if I see 15 people or 20 people in a day, I'm using it on probably 75% of them.
Okay.
And you know, that's it. Really, anybody with any kind of spinal pain, all of my headache patients, I look for it, whether I need to perform it or not. It's not probably 50% of the time I need to do it. And then my athletes in general, I always look for it because it's an easy look. I mean, it takes literally 2 seconds to look for that counter nutation. If it's there, we fix it. If it has something to do with their problem, great. If it didn't have anything to do with the problem, it was bound to become a problem down the road anyway. So we fix it, and it's too quick not to worry about.
Speaking of speed and fixing things, have you found that once it's fixed, it's not something that you have to repeat in the next visit?
Yeah, very rarely do I ever have to do it a second time. There are times, that's the nebulous part of the technique is that I can't guarantee that you'll never have to repeat it, but it's really rare that I have to repeat it. Maybe one patient every couple of months that I'll have to do it a second time, and then we'll talk, I think, about some things that might monkey it up, that you have to fix those things for the technique to be 100% effective. But I mean, almost always it's 100% effective, even when those things exist.
What percentage of pain relief do you expect if the technique works for someone before they walk out the door?
I would expect about 50% effectiveness, pain relief on the first visit. And there's some assumption there that, the patients who are really chronic, who have had their problem for years or decades, I'm not going to expect quite that big of a result, but still they're going to have a definite improvement on day one. The folks that are more acute, if they have their pain for a month or less, I'm going to expect their pain better right away.
Do they tend to hold the improvement from the first to the second visit in terms of when they come back to see you? If they need another session, do you find that they're at least maintaining what they achieved when they walked out the door the first time?
Yes. Yeah. And part of that is that there's a home exercise that goes with it. In the patients who are diligent about doing that home exercise, they always come back better. Okay. And the folks that don't still have improvement, but it's not quite as good.
Sounds like you're ready to do the feel better in 3, or the third one's on me. You
absolutely. Yeah.
Throw down that gauntlet challenge, right?
Yeah. Yep.
Can I just verify to make sure I know? So when you're saying counter nutation, you mean the sacrum is extended, or what do you? Because
that's the hard part about how to name this, because the assessment would be to have the patient supine, look at the ASIS level. And what's interesting is 100% of the time, it's always going to be the left ASIS that's elevated or higher in relationship to the right.
You mean superior, or you mean anterior?
Rotated superior.
Okay. Wait, so can you say that again?
If you were to take the pelvis and just twist it, that's what it looks like.
Okay, so you're saying the left side would be anterior. Is that what you said?
Correct. Superior. Yeah.
Okay. And so you're calling that left side counter nutation.
Yeah.
Calling that.
Yeah, that's what I always name it by the high side. It just, it makes it easier for my other therapists to know what I'm talking about. And like I say, clinically, we call it an upslip, although I know that's a really terrible name for it.
Yeah, because that would be
Right.
It's that,
But,
and then okay.
yeah, it's just,
You have to get that clear.
yeah, I
Because
would agree with that.
usually I think when from how I learn it, I don't know, everybody obviously has learned it differently because I learned it as it would be the sacrum flexion is nutation and the sacrum and extension is counternutation. And then you'd name the rotation as anterior rotated ilium or posterior rotated ilium. So, I mean, I'm just talking about for the name, but
Right.
okay, but I understand what you're saying.
Yeah.
Okay, awesome.
Yeah. So it's one of the interesting things to me is how it's always 100% of the time, it's always the left side that's elevated.
That's cool.
Yeah. Part of what we actually chatted about, so you all know, was that we were playing around with what it should be called, what we should name it. So, I mean, since you all are part of this first launch group, feel free to send us feedback about what you think, if there's something that might more appropriately fix it or fit it, that, we're happy to explore those options. Yeah.
Yeah, I guess, Tom, I'm still a little confused. Is it superior, meaning closer to the head, or is it anterior, meaning closer to the ceiling when they're supine?
Yeah, closer to the head.
Okay, thank you.
Mm-hmm.
I had in my notes, Tom, let me know if you've already gotten this question from Deb. We put our heads together and came up with some questions so that we could kind of get a better sense for everybody. If for those few cases where there's not an improvement that's held, what are you looking at to improve the results?
Right. So I would say the most consistent problems that exist when I do the technique and the patient comes back and that I see the problem again, probably the most consistent is fascial mobility over the sacrum and or the proximal gluteal region. The other interesting thing is just immobility of the SI joint. And so I'll do some SI mobs, obviously some other PERT techniques. I'll also do a Mulligan technique on the hip. He calls it a PRP, a pain relief phenomenon technique. It's a pressure technique. And that tends to loosen up the SI joint, and then we can get much more effect. But those are usually the only things that I see that would prohibit the technique from working on the first trial. And even then, the technique works on the first trial. It just doesn't stick. It doesn't hold.
Well,
Yeah,
given that you're being candid about that, so if you saw them back a second time, would you expect that to hold the second time? I mean, in other words, how many times would you see them and still repeat the technique before you would be concerned there might be something else that you're not addressing?
I don't know that I've ever done it more than twice on any singular person.
That's what I was trying to get from you to find out. Okay.
Yeah, I'm trying to think back at some of the more difficult cases, people who have had herniated discs that ended up needing surgery, but even them, the technique works on them. It just doesn't fix that herniated disc.
Is there a difference between men and women in terms of the frequency that you see this pattern?
No, I've not noticed a consistent pattern one way or the other. And the other interesting, that leads me to think the patients will always ask me why is this pattern there? And I honestly have no idea. In my 30 years of being a therapist and my 25 years of working on this technique, I have no idea. I've seen it in very young, like pre-teens, and I've seen it in 80-year-olds. I've seen it in athletes. I've seen it in couch potatoes. I really truly don't know why this pattern exists.
I have a question that just came in from Therese. Do you want, let's see, where's Therese? Do you want to go ahead and post your question to Tom?
I thought I did. So
Oh,
my was, so when we're looking at it, so you're saying that the left side is rotated posterior or superior. So then do you consistently see that the right side is then rotated anterior? So the right ASIS is always low compared to the left ASIS, which is always high?
Yes, it's exactly right. I always name it by the high side just so that we're not naming both. But yeah, that's 100% of the time, that's always the pattern.
And then is there a pattern of the leg length? So do you always see that the right leg is short compared to the left leg?
Almost always. There are some occasions where I don't see the leg length. I use the leg length as a secondary test just to confirm the finding. And I do always make sure my patient's lying properly on the table. I do a little traction, manual traction, to make sure they're not just hiking one hip for one reason or another. But yeah, secondarily, I always check leg length, and obviously the left leg is always going to be longer when you have that rotation.
Got it. Thank you.
Mm-hmm.
Tom, what would Kim was asking, what kind of symptoms someone would present? Is there a classical pain pattern that you would see?
I wouldn't say it's a classical pain pattern, but some things to look for besides just your typical low back pain are groin pain, sacral pain, and then interestingly enough, radiculopathy, very consistent with sciatica, but it might not be that true sciatic radiculopathy down the posterior aspect of the leg. It could be down the side of the hip and thigh. I've even had some people with ankle pain, lateral ankle pain with this. So it mimics like a neural compression.
Awesome.
Yeah, the SI joint is known to have several of the sacral roots that innervate it. So that's where you could be getting those distal symptoms all the way down to the foot.
Right. Yeah, so this is, I would strongly suggest anybody that walks in with groin pain, obviously the first thing you think about with groin pain is hip problems, because that's the most consistent problem that's going to refer pain to the groin. But check for this when you have groin pain as well.
Got it. Thank you. Dad, did you have any other questions, Tom?
Well, so Tom, let's go back and have them benefit from how long you've been doing this. When you see someone on the first visit and you do what your training will show them to do, is that all you're going to do, or what else might you add to what it is that your protocol? What would you? How much do you try to get them totally out of pain before you send them out the door? Is what I'm trying to get at.
Gotcha. So yeah, this, after I do my assessment, this is the first thing I look for, because it's such a simple technique, just like PRRT is. So it's the first thing I look for. I do my technique, and then I'll probably, I will always do a couple of PRRT techniques because from the findings I have from my PRRT assessment, I may or may not do some hip mobs if I feel that SI joint's particularly tight. But yeah, I work, this is just one more technique. I just think that this technique unlocks all the other techniques that everybody's been doing. It just makes it easier. It's like I've described PRRT as being WD-40. This technique is WD-40. It just makes everything else we do easier and quicker.
One question that I posted to you, Tom, that I think everybody else would benefit from as well was when I asked if somebody had been through all 5 levels of PRRT training, would this be something new that they would feel like they're experiencing? Can you speak to that?
Yes, it'll have a PRRT feel to it, but it's not a technique that they've ever seen. I've looked all over social media, I've looked through articles, and I've not seen anything like this technique. It has a little bit of a feel. In fact, when I first started using it, I used a lot of muscle energy technique to try to make it work. So it has a little bit of that feel. It has a little bit of PERT feel to it, but it's very unique. I've not seen it, and I'm looking hard trying to find something that looks like it.
Well, you know, it sounds as if, and I think probably most people would agree, it sounds as if it's too good to be true.
Yes.
But knowing you, and how long have we known each other now? How many decades are we
I
talking
don't.
about?
I sometimes forget. I think it's sometime around 2003, John.
Yeah, we've been together a long time.
Yeah.
So I know you to know that you aren't into hyperbole. You don't say things that aren't true. You don't say things in exaggeration. That's not who you are.
Right.
But there should be
Like
some
you.
way that if people
Yes.
are interested in this, that you can make this something that they can give a try to and see whether it is, in their experience, what it is for you. Have you considered something like that?
Yep. We've talked about that. You know, the mini course comes with a money back guarantee. If it doesn't work like I say it does, you can get your money back.
And then what's this about you saying that if they had questions, they could call you or email you?
Yeah, that's one of the things that I thought, just because this is my first real trial of doing something like this. And I had mentioned briefly too, that, you know, you're the one that convinced me to do this, because it's such a powerful and quick technique. It's such a great piece in the toolkit.
Yeah.
That because it's my first time doing something like this, I wanted to offer something that I don't think I haven't seen too many people offer, and that is my email, my phone number. If you have any questions or problems with the technique, you're free to get a hold of me. I'm available to discuss any problems or any reasons the technique might not be working.
That is very unique in the realm of people who produce courses on technique.
I know. So, but I'm very confident in this technique. I've, like you are of PERT, I've been doing this for a long time. So it just never doesn't work.
Before I tell them a little bit more about how they could go check it out immediately, because we have it finally all ready for them, I was going to open it up to see if anybody else had other questions. I noticed that Jeff recommended you just call it the Krupar.
Is that Jeff Moyer?
Yeah.
So maybe Jeff could, because Jeff may be the only PERT practitioner who's ever seen the technique. I just was playing with it one day at the course that he took, and so he's seen it.
I was wondering if that was it.
Yep, that was it.
Okay, so I got some testimonials for it, because that's
Awesome.
that's my go-to. There's variants of how I do it, but that's honestly my go-to, regardless of what technique or what I'm doing. I start there. I'll just tell you a weird story. Like, I work with a girls' soccer team, and in the middle of the workout, this one girl was like, "Coach, my Achilles is feeling pretty tight." I said, "Okay, mind sitting down real quick?" And first thing I do is I check the ASIS. She was off. I had her do the technique, and as she was doing it, you know, I looked away to talk to another girl, tell her what to do for her workout, and 5 seconds later, 10 seconds later, I turn back, the girl gets up off the floor. I was like, "No, wait, hold on, you weren't done." I was like, "Yeah, my Achilles feels good now. I'm good." And she just got up and left, and that was it. I've seen it fix, seriously, groin pain, quads, hamstrings. Jess knows. I talked to Jess a lot about it. Langbart, it's my go-to. It's part of it's my primal. Yeah, Tom taught me that for my knee when I was I don't know, level 2, I think it was.
Yeah.
Yeah, it works. It works. It fixes any kind of lower extremity stuff. It's pretty good.
Thanks, Jeff.
you. Thanks, Jeff, for giving us that.
Yeah, Jeff, we appreciate that. I think that now kind of makes sense as far as, you know, our struggles to name it, because what we were talking about is it's so much more than just, you know, something that addresses, you know, pelvic and SI and low back and stuff. So that's cool to hear. Thank you.
I want to throw another piece into the equation, which I don't know, Tom, if maybe you can comment if you tried this, because I've not asked you this. How many of you remember put your hands up if you remember that I've taught you that the fascia of the diaphragm extends into the pelvis. You want to put your hand up if you remember that? Gosh, I'd feel bad if there weren't a lot of hands that went up, because that would make me feel like I didn't teach you what you should. So my other piece of the equation that I would say, you wouldn't have to start with checking the diaphragm. You can check ribs 6 through 9. That's a good way to just make your assessment. Strum ribs 6 through 9, bilateral on both sides at the same time. And on the involved side, they'll be crepitus. And they'll probably act like it's ticklish, but it won't be ticklish on the opposite side. You can see after you've done the technique of Tom's whether that clears or not. But given that Tom has even admitted that there's some cases where he does some follow-up with people, it might be that the diaphragm could be maintaining some of the memory of the restriction to the SI joint. So I would always talk about, making sure you reboot the diaphragm like I've taught you to do.
Tom, it looks like you have
What's
another.
your take on that, Tom? Tom, you got a comment on that?
Yeah, absolutely. And that's why I want to make sure that everybody realizes this is not the only technique that I ever do. I mean, people don't come in, I do this technique and they leave. I do a lot of PRRT. I do a lot of myofascial release. And yeah, I can't, in the course, I describe what I think is going on, what musculature is involved, what joints are involved, and what all the technique tends to do. But it's still, I can't put a finger on why the technique works, but I can guarantee that it works.
So another thing for you to all consider when you're seeing people, whether it's live or doing telehealth, is people who've had disc surgery, who still have some degree of radicular complaints. That's pretty common, that they don't get 100% improvement. Again, most people who they would be treated by would not be thinking about doing what Tom's talking about. So Tom, have you got any experience with people like I'm describing, men or women who had HNP and then had disc surgery to try to resolve it, theoretically to resolve their leg pain, and they got some relief but not total relief, and then you took care of the rest of it? Have you had that experience?
Yeah, absolutely. That's the cool thing about the technique is you could name the type of patient, and I've used it on that patient and had some success with it. So I do believe that there's a big influence on the psoas. Because of the influence on the psoas, you have influence on the discs because of those attachments to the discs, lumbar discs.
Yep. Okay, great.
Tom, you had a question, it looks like, from Marlena. Did you still have a question? Nope. Looked like the hand went up. So
I don't even know how to make it work.
There's a little hand symbol that came up, so it's all good. Was there any other questions for Tom? Well, we have you all. Like we said, this is super exclusive access to have once you get the program and review it. If you have any questions, Tom put his contact information in there. You're going to get an eval form. You're going to get technique pages included with it. Lifetime access. Anytime Tom has any future course updates, those will be included. And it's, like we said, a 30-day money-back guarantee. So exclusively for you all, it's normally going to be $127. What we're doing right now is $97, and that'll be available until this Friday. So I'm going to post the link here, and feel free, that'll take you right to the purchase page. If you can follow that, I can email it to you as well. I'll probably send out the link to the Facebook groups. Let's see. The other thing I was going to say is, Tom, did you have any other thoughts?
Wow. No, I don't.
Well,
Yeah,
Tom, I've got a couple questions for you
yeah, great.
before we finish up. Women after childbirth who have symptoms in anywhere from back pain, buttock pain, vaginal pain, leg pain, have you used it on that patient population?
I wouldn't say many times on postpartum, but I've used it pretty regularly on pregnant women. In fact, I just had a pregnant woman on Monday. She's 9 months pregnant, and this technique worked very well on her.
Okay.
You know, it's safe, it's effective. She can do the home exercise, so it's very safe technique to do.
Okay.
So I guess maybe you said this, but it's gonna be virtual, but it's not live. You do it on your own pace, or like what's the format?
Yeah, it's just like any of John's mini courses. It's all on video, and yeah, you can do it at your own pace.
Yeah, it'll be on the same members area as the other mini courses.
Okay.
So you'll be able to see it there. The other thing I was going to say is, since obviously this is rare times for everyone, please feel free to reach out to us if you need any assistance with a payment plan or anything like that. We're happy to help you with that.
I think I saw a question of, is the home exercise included on the mini course? And yes, it is. The course is me talking about the technique and how I developed it and what I think is involved with it. An explanation of the assessment, an explanation of the technique, and then the home exercise that goes along with the technique. I think the technique is, I've found that it's much more likely to hold if the patient's compliant with the home exercise afterwards. The hard part is how long do they need to do the home exercise? And I wish I could tell you I had a real definite answer to that, but I would say, generally speaking, I have people do that exercise, that home exercise, for about 2 weeks after we get the correction. And then at that point in time, the correction maintains and they shouldn't need to do it anymore.
How many of you, with a show of hands, think that the sacroiliac joint reflects emotionally what's going on with people now that we're in the coronavirus era? How many of you, hands up if you think that that's having some influence on the SI joint? Yeah, because it's very autonomically wired, especially in women, to a lesser extent in men, but it's such an important joint. And I'm getting kind of emotional saying this, but I've talked about President Kennedy with his back pain and how much he had done treatment-wise with Janet Travell, trigger point injections. But I wonder, with his PT boat accident, if his sacroiliac joint was involved and if he ever got treated for his SI joint, because everywhere he went, he had to wear a back brace. In fact, that's what he had when he was shot in the motorcade in Dallas. He had his back brace on. And I wonder if the fact that she continued to treat him, she doesn't indicate whether she treated the SI joint. Her big thing with him was the quadratus lumborum. But the quadratus lumborum, as you may or may not know, if you remember I told you about this, the attachment of the quadratus morphs from muscular fibers into ligamentous, becomes part of it becomes the iliolumbar ligament when you get into your late teens. That is contiguous with the posterior sacroiliac ligaments. So I wonder if, even though that's where she was injecting him, thinking that that was his referred pain pattern, if in fact he would have benefited from, and maybe never got any SI joint treatment. And that's why he continued to wear his back brace. So just a thought that I've had, and I have no answer for it. There's no way we'll ever know.
You know, John, something you said there made me think too, is that sometimes this rotation or this counter rotation, or however you want to name it, that left ASIS, sometimes is a good inch and a half higher than the right side. And all the literature will tell you that there's only about 3 degrees of rotation in the SI joint.
Yeah.
So why such a large shift or rotation makes me believe that the lumbar spine is involved, and to some degree the hip joint might be involved as well, and
Right.
why it looks visually so off. And
Always do.
Yeah.
Remember to check the psoas major, especially, not so much the minor, not so much the iliacus, but that psoas major is such a reflection of what's going on in the entire pelvis. So very important that you try to at least palpate the insertion on the lesser trochanter and see whether there's a sense, or you can put them prone and try to extend the hip and get a sense of whether they have restricted hip extension as a result of the psoas being in a facilitated state. Because I have a feeling, Tom, whether you look at it or not, that if you were checking the psoas, you would notice the change in the psoas as well. Do you have any sense of that from having checked psoas before and after your technique?
Yeah, very much so. Because I do, like I say, I do a fair amount of PRRT along with this technique. And so I always do, the psoas secret. I would say almost always do the psoas secret with this technique.
Mm-hmm. Okay, good for you. Does anybody have any other questions for Tom or any other thoughts on? Okay. So Eric, do you want to do a wrap then as to where we are here?
Yeah, I was just going to remind you all that you can go to superspinemember.com and then click the buttons up at the top that say PRRT mini course. It's listed there just in case the link didn't work to get through. It looks like we've already gotten a few orders in. So if you're on and listening, I'll get that sent to you right away as soon as we're off with this call. Dad, did you have any last thoughts?
I want you to know that this is not something that I do with lots of people, meaning to promote their work. And I think Tom has gone out on a limb to offer all that he's offering you, especially that he's giving you not just a money-back guarantee, but access to him. I can't think of anybody else I've ever bought a training from who said, here's my phone number, here's my cell number, call me anytime you have any questions. I can't remember in my lifetime ever having one person say that, which is extremely unique. And I think it's very generous. That's who Tom is. I mean, I know Tom, and he's that kind of person. And I encouraged him to put this training together when he told me the success he was having. And I want you all to experience it. And I want to hear from you if you purchase the course. I want to hear how you're doing with it, because it's going to be important for me to hear the feedback from us, giving you the opportunity to use what Tom finds is very helpful in his practice. So hopefully you'll give it a try, and no hard feelings if you don't find it's helpful and you want your money back. You'll have to come after Eric for that, but other than that, right, Eric, they'll have to come after you.
They know where to find me.
Yeah. But I think it's worth a try, folks. I really do think it's worth a try, and you can't find a better deal than what he's offering you. So that's probably all I could say. Anybody have anything that they would like us to focus on our next call? Anybody have anything that they feel is something that would be valuable during this time that we're going through?
Well, Jeff, do you want to propose your topic and see if others would be interested in a discussion on that?
Sure, let me find the particular thing I sent you.
Sympathetic nervous system and its
the effects of the effect of the sympathetic nervous system on its role in the skeletal muscles.
Yeah,
be curious,
great. That's a great topic. It's a great topic.
Talk about that.
We'll see what we can put together on that. Have you done some research on it yourself?
A little bit, yes.
Yeah. Well, be in touch with me with what you've got, and then I'll supplement it with what I can find.
Okay.
I've already got.
Can we do a quick survey while everybody's still on? If you would raise your hand if you're interested in a discussion on that topic, so that we could.
Can we see hands if that's a topic of interest?
Okay.
Thank you.
In other words, here's why every hand should have gone up. In this day and age, who isn't sympathetically upregulated
How do you do it?
with what's going on in terms of our life, our income, our future? I mean, we're all in a state of uncertainty, and it has to have some effect on upregulating, putting you in a more hyper alert state, a sympathetically upregulated state, if you will. Even if you don't acknowledge it, unless you're just happy as you were before this all started, then maybe it isn't affecting you. But I doubt that's true for most of you, including me. Okay, and as you get older, it's tougher. Believe me, it's tougher to have this kind of a major change. You know, you get used to a pattern. After 75 years, you get used to a certain pattern. There's not too many of you on the call here that are that age. So, you know, I think I'm the senior person on the call. Joey, you look like you're older than me, but you're
Well,
not.
I was going to say, you would know.
Well, no, it's the loss of hair for you and Chris that make you look older, but
Yeah, you would know about all that stuff, John.
anyway, I thank you for all your participation and for joining us. It's always nice to see all of your faces and to hear your interest in our work. And I'd like to hear from you if you purchase Tom's course, how it works for you. I know he'll want to hear from you too, but I also want to hear from you. And then be in touch with Eric as far as future topics that you'd like to be talking about, and we'll try to accommodate them.
Yeah.
Okay, Eric?
I'm sorry for the delay in this. We wanted to make sure that it was all ready to go and share it with you as soon as possible. And so we had to take a couple weeks off, but yeah, I wanted to, before we do, Kamika, it looked like you raised your hand. Was that a question or you, okay, go right ahead. No? Okay,
No, I was just responding to his,
Got it. Well, one last thing, I was gonna unmute all of you so that you could give Tom a quick hand for being here. Thanks again, everybody. I'll be in touch soon. I'm watching a bunch of different orders come through, so those will be coming out to you in the next 5 minutes. Just check your inbox, and if you don't see it, double check your spam folder just in case. Let me know if you don't see it. So otherwise, we really appreciate you all being here, and it's awesome to see you, and hopefully we'll see you again next week. All right? Thanks again for being here, everybody.
everybody.
Thanks, Tom.
Bye, John.
Bye. Thank you.